There is something I need to say, and I know not everyone in my profession will agree with me. For more than 20 years, I have practiced medicine in the United States. I have seen incredible advances in technology. I have also seen something else. I have seen healthy people slowly turned into patients simply because we kept testing. We are told that prevention is everything. Catch it early. Screen for everything. Stay ahead of disease. That message sounds responsible. It sounds smart. But after the age of 60, more testing does not always mean better health. Sometimes it means more appointments, more specialists, more procedures, more anxiety. I am Dr. Javier Morales, and today I want to talk honestly about 5 medical tests that often create more harm than benefit for people over 60. This is not about avoiding doctors, it is about understanding what happens after a test finds something small. Because once something is discovered, even something harmless, it can trigger what we call a medical cascade. One test leads to another leads to a procedure, and somewhere along the way, your quality of life changes. At this stage of life, the goal is not just to live longer, it is to live well, to protect your independence and your confidence. So before you say yes to every screening offered, you deserve to understand what you are signing up for. Let us talk about it. Before we talk about specific tests, you need to understand something that quietly shapes modern healthcare in America. It is called the cascade effect. Here is how it usually begins. You feel fine. You go in for a routine visit. Maybe your doctor suggests an extra scan just to be safe. Maybe it is part of a hospital protocol. Maybe you asked for it because you wanted reassurance. The test comes back showing something small, a tiny spot. A slightly abnormal number, a shadow that was not expected. It might be nothing. In fact, most of the time it is nothing. But in medicine, once something appears on a report, it cannot simply be ignored. Doctors worry about missing something serious. Hospitals worry about liability. Specialists want to be thorough. So the safest next step is usually another test. That second test may still not give a clear answer. So now we are talking about a biopsy, or a procedure, or a referral to yet another specialist. Each step sounds reasonable on its own. No single decision feels reckless, but taken together, they form a chain reaction, and every link in that chain carries risk. There is the physical risk, infection, bleeding, complications from anesthesia, medication side effects. There is also the psychological risk. Once you are told there is something, it changes the way you see your body. You begin to monitor every sensation. Every ache feels suspicious. Every appointment carries tension. And sometimes, after months of follow-up, procedures, and stress, the final answer is this. It was harmless all along. Nothing was ever going to threaten your life, but the cascade already changed it. This pattern becomes more common as we age because our bodies naturally accumulate harmless changes. Small cysts, mild plaque buildup, age-related shifts that are normal for a 70-year-old but look abnormal on paper. The older you are, the more likely it is that a highly sensitive test will find something, and once it does, the wheels start turning. That is why the real question is not simply, can we test for this? The real question is, if we find something, will it truly make you better off? With that in mind, let us start with the first test that often triggers this cascade. Let us start with a test that sounds incredibly modern and responsible. The full body scan. You have probably seen the advertisements. A single scan that looks at everything from head to toe. The promise is simple. Find hidden disease before it finds you. For someone over 60, that offer can feel empowering. It feels proactive. It feels like control. But here is what often happens in reality. A healthy 65 or 70-year-old walks into a clinic for a full-body MRE or CT scan. They feel fine. No symptoms, no complaints, just curiosity and caution. A few days later, the report comes back. It mentions a small lung nodule, a tiny kidney cyst, a shadow on the liver. The radiologist recommends follow-up imaging in 3 to 6 months. Now that person who felt completely healthy has something to worry about. Statistically, this is almost guaranteed to happen. Studies show that when you scan healthy adults, over 60 incidental findings appear in the vast majority of them. Small abnormalities that are simply part of aging, like wrinkles on the inside. Most of these findings will never cause symptoms. They will never shorten a life. But once they are documented, they cannot be ignored. Follow-up scans lead to more radiation if it is a CT. A specialist may recommend a biopsy. A biopsy carries risk, infection, bleeding, complications from anesthesia, and after months of monitoring and anxiety, the final conclusion is often the same. It was harmless. The scan did not extend life, it did not prevent disease, but it did create stress and sometimes unnecessary procedures. Now, let us talk about another test driven by fear. The brain MRI for mild forgetfulness. A. 75-year-old forgets a name, misplaces keys, walks into a room and pauses. These are common experiences of normal aging, but the fear of dementia is powerful. Families push for imaging. They want certainty. The MSRE report often includes phrases like mild atrophy, small vessel changes, white matter lesions. Those words sound frightening, but in most people over 70, they are expected findings. They reflect aging, not necessarily disease. The problem is that images do not measure function. I have seen patients with concerning looking MRI, TRs, who function beautifully. I have also seen the opposite. For mild memory complaints, a careful cognitive evaluation, medication review, sleep assessment, and blood work often provide more useful answers than a scan. The image may look dramatic, but it rarely changes management in early mild cases. In both of these situations, the pattern is the same. We go searching for reassurance, and we end up creating uncertainty. The third test I want to talk about is the routine cardiac stress test performed simply because of age. This often happens before minor surgery. A 72-year-old is scheduled for a knee replacement. He walks daily. He climbs stairs without chest pain. He feels fine, but because he is over 70, the protocol recommends a treadmill stress test. On the surface, it sounds cautious, but here is the problem. Stress tests in older adults have a relatively high rate of false positives. That means the test suggests a blockage when there may not be one causing real danger. Age-related changes in heart rate response medications or minor plaque buildup can all make the test look abnormal. Once that result appears, the cascade begins. Now the patient is referred for a cardiac catheterization. A tube is threaded through an artery into the heart to visualize the vessels. It is invasive. It carries risk of bleeding, stroke, or complications, and frequently what doctors find is exactly what you would expect in a 70-year-old heart. Some narrowing, some plaque, nothing that was about to cause a heart attack tomorrow. But something else has changed. The patient now sees himself as a heart patient. He becomes cautious. He limits activity. He worries. New medications are started sometimes with side effects that affect energy and blood pressure. All of this began in someone who had no symptoms. Now let us talk about a test that carries even more emotional weight. The PSA blood test for prostate cancer in men over 75. Cancer is a powerful word. No one wants to ignore it. So when a PSA level comes back slightly elevated, it creates immediate fear. But many prostate cancers in older men are extremely slow growing. Studies have shown that a large percentage of men in their 70s and 80s have microscopic prostate cancer that would never cause symptoms during their lifetime. Yet once a PSA rises, biopsies are performed. Biopsies can cause infection and bleeding. If cancer is found, surgery or radiation may follow. Those treatments carry real consequences. Urinary incontinence, erectile dysfunction, fatigue, bowel issues. And here is the difficult truth. Many men die with prostate cancer not from it. When life expectancy is limited by age or other health conditions, aggressively treating a slow-growing cancer may not extend life, but it can absolutely reduce quality of life. This does not mean PSA testing is always wrong. It means that after 75, the decision must be individualized and thoughtful, because once again, the cascade begins with a single number on a lab report, and that number can change everything. The fifth test I want to discuss is routine colonoscopy after the age of 75, especially in people whose previous screenings have been normal and who do not have specific high-risk factors. Colonoscopy is a powerful tool. For adults in their 50s, 60s, and early 70s, it prevents cancer by removing precancerous polyps before they become dangerous. There is no question that it saves lives when used at the right time, but medicine is always about balance. Colon cancer typically develops slowly. In many cases, it takes 5 to 10 years for a small polyp to grow into a life-threatening cancer. That timeline matters when we are making decisions in someone who is approaching 80 years old. The risks of colonoscopy increase with age. The bowel preparation can cause dehydration and weakness. Sedation becomes more complicated in older adults and may lead to confusion or breathing problems. Most concerning is the risk of perforation, a tear in the colon wall. While uncommon, that risk rises significantly after 75. And when it happens, it often requires emergency surgery. Emergency abdominal surgery at 80 years old is not a small event. Recovery can be prolonged, independence can be affected. In some cases, it permanently changes quality of life. If a person has had normal colonoscopies for years and has no family history or inflammatory bowel disease, the likelihood of finding a dangerous new cancer at 80 is relatively low. Meanwhile, the procedural risks are higher than they were at 60. This is why many medical guidelines suggest stopping routine screening somewhere between 75 and 85, depending on overall health and life expectancy. This does not mean ignoring symptoms. Blood in the stool, unexplained weight loss, persistent abdominal pain, or anemia should always be evaluated regardless of age. But continuing routine colonoscopies automatically simply because it has always been done may not always be the safest choice after 75. After more than 20 years practicing medicine, I have come to a conclusion that may surprise some people. Technology is not the same as wisdom. We have more imaging machines, more lab panels, more screening tools than ever before. And when used appropriately, they are life-saving. I have seen early detection change the course of someone's life in beautiful and powerful ways, but I have also seen the other side. I have seen strong, independent men and women slowly lose confidence in their bodies because of a test result that never would have harmed them. I have seen people labeled as heart patients, cancer patients, or neurological patients long before they ever experienced symptoms. I have seen procedures performed out of caution that left someone weaker than before we started. That is why my personal philosophy has changed over the years. When I was younger in my career, I believed more information was always better. Now I ask a different question. Will this information improve this person's life in a meaningful way? Because health, especially after 60, is not just about adding years. It is about protecting function, protecting independence, protecting peace of mind. If a test helps you stay active, confident and well, I support it fully. If a test is unlikely to change management and carries real risk, it deserves a thoughtful conversation. And that is my most important message today. This video is not medical advice. Every person is different. Your health history, your risk factors, and your priorities matter. Decisions about screening should always be made in partnership with your own physician who understands your specific situation. My goal is not to tell you what to refuse. My goal is to encourage you to ask better questions. What will we do if this test is abnormal? Will it truly extend my life? Will it improve my quality of life? What are the risks at my age? You deserve clear answers before you say yes. Medicine works best when patients are informed and engaged, not fearful, not passive. Sometimes the most powerful choice in healthcare is not doing more. It is choosing wisely.